Assalamualaikum everyone. Good morning. Welcome to our sixth session of recall based. So these are the list of topics we are going to cover today. First, we have this obsessive compulsive disorder. Let's go to MTP page 371. It's a very interesting topic. So for this obsessive compulsive disorder, we actually have two things. So one is obsession and second one is compulsion. So maybe you will have some questions related to only obsession and you will have some questions related to compulsion, or both together, obsession, compulsion. So we need to know what is actually obsession and what is actually compulsion. So obsession can be alone, or most commonly combination of compulsion and obsession will be there. Typically affect the individual's level of function. What is actually happening here? So thoughts that are intrusive or senseless and distressing, thus increasing anxiety, and include fears of contamination. So say, for example, if I have a thought in my mind that my hands are dirty, only there is a thought, I'm not going to perform any action, I'm not going to get up and wash my hands. So if only there's a thought is there in person's mind, that's an obsession. It's only a thought. But once the person gets up and wash his hands, so this is a compulsion. He has to perform that action in order to minimize the fear of that thing, like the hands are dirty. So once the action is done, then only you will say it's a compulsion. But once only the person is having thought in his mind that he has dirty hands, or maybe some alien is there in the backyard, or maybe someone is talking to me, or maybe my baby crab has so many snakes over. So just only a thought. But once the person gets up and wash his hand and go and check in the backyard for the alien multiple times, and go and check for the baby multiple times that the baby crab must not be having any snakes over it. Also, once the action is done, then only you will say it's a compulsion. So compulsion is rituals such as counting and checking done to neutralize thoughts. So whatever the thoughts is there in a person's mind, of course, those thoughts are senseless. And sometimes patients do admire themselves, okay, these thoughts are senseless. Say, for example, the person says that I have aliens in my backyard, and they realize that this is not possible. But don't know what happened to them. They just keep on thinking this thing. So if they keep on thinking these senseless thought, it means obsession. But once they go and check out themselves, and because in order to minimize the fear of having aliens in the backyard, then it's a compulsion. So once the action is done, compulsion is there. So we'll see so many recalls based on this one. So how you're going to diagnose? Of course, it can be in any age, but most likely young patients are involved. Men-women ratio will be same as there. So what you're going to go. So if the patient is really having these senseless thoughts which are actually causing fear to the patient, harm to the patient is in anxiety because of those thoughts, patients are in depression, of course we are going to start SSRI, which is the first line treatment for the depression. So most commonly we will use this fluoxetine, paroxetine. So fluoxetine is actually the choice of drug which we can use, but don't start over now. First, we will always go for the counseling, but these patients always ended up in having these antidepressants. Main behavioral therapy use exposure and response prevention. They go and check, it's okay, but multiple times it's happening again and again and again, causing depression in the patient because of these thoughts and because of these actions. We have to start SSRI. So let's have a question. The first question says, a mother of a 3-month-old baby presents to the clinic and tells the physician that she is going crazy. She stated that since the baby has been born, she has continuously visualized a snake crawling into the baby's crib at night. She stated that she knows it is not likely to happen, but cannot get the thought out of her mind. She checks the baby crib up to 50 times per night to ensure that there is no snake. So she doesn't only have this fear of having the snake crawling on her baby, but also she is going to go and check 50 times per night to ensure that there is no snake. So which of the following is the most likely diagnosis? Do you think it's a delusion, it's obsessions or hallucinations, or postpartum psychosis? Actually, this recall I have asked multiple times from the doctor that only obsession was there or OCD was there, but she was keep on telling me that only obsession was there. anyhow, it should be OCD complete, because the patient is not only having a thought in her mind, but she is actually going and get up and seeing the baby 50 times at night. So compulsion is also there. So the ideal answer should be OCD, obsessive compulsive disorder. But as per the doctor's recall, she was saying that she only had the choice of obsession, and other than that, the options are not relevant. So we'll go for obsessions, but it should be in your mind that it's a complete OCD, because she's not only having the thought, but she's also, minimize the fear of having this snake by checking the baby. So here the answer is obsessions.
Dr. Hira, why not hallucinations? She is seeing.
No, dear. She's having this thought in her mind that this is not the right thing. The person who is having hallucination, they will always argue with that they keep on listening, they keep on seeing, and they keep on feeling those thoughts. It's not like that they will say to you, okay, I know this is a senseless thought that I'm hearing my father's voice, who has been dead for the how many years, but he will keep on saying you that no, it's real. I'm hearing those voices. I'm seeing them, something like that. So that they will say they are definite in that thing. But in OCD, the patient, for the obsession, patient knows that this is a stupid thing, this is a senseless thing. It's something not like that. But what can I do? I have this thought in my mind. In order to minimize the fear, I have to go and check. Something like that.
Okay.
So for the second question, a 21-year-old woman presents to the clinic with history of... Yes, dear.
Why not delusions?
No, delusions is false perception. False perception, having false thoughts in mind. So, but here there is nothing false. She usually gets up, watch and check. The baby is already there. Everything is real.
But you cannot say that. False perception.
Yeah, false perception. See, in delusion plus illusion. Illusion, maybe there is a pillow over there, and she's going to mimic that pillow with the snake. So there is misinterpretation as well. But here in this case, it's not like that. The pillow is there, and she's perceiving that pillow is not a pillow. Actually, pillow is a snake. So that is illusion with delusion, like having a misinterpretation as well. But this is not the case.
If she is taking this pillow as a snake, then it will be a delusion.
Then it's of course. Okay, now a 21-year-old woman presents to the clinic with history of red, dry skin on her hands. She washes her hands up to 70 times per day because she always feels dirty. Washing her hands relieve her anxiety, but as she touches anything, she wants to wash again. So there's obsession again here, and washing is also there. So it's a complete disorder. Which of the following disorder is the most likely diagnosis? So again, obsessive compulsive. So both things are there. So this is a complete OCD. She's not having a thought of dirty hands, but she's going to wash and wash again. Again, a 56-year-old woman presents to the clinic with history of constant counting of floor tiles, cars, items on a dinner plate, and words in a conversation. There's a counting of these floor tiles, again and again, counting of cars and counting of words in a conversation. Of course, a senseless thing. She's upset by the counting, but becomes anxious and agitated. So she has to count. Otherwise, she will become anxious and she will become agitated when she tries to stop herself from counting. So which of the following is the most likely diagnosis? So what do you think? What it should be? Now you have to discriminate between obsession and compulsion. Do you think it's an obsession or do you think it's a compulsion? You have to choose in between these two. What you're going to choose?
Compulsion.
Very good. It's a compulsion. So how you're going to define compulsion? She's not only counting the tiles, but also she is very anxious and agitated. And in order to avoid this thing, she's going to count by herself. So in obsession, she will not count anything. But in compulsion, she will complete the act. So whenever they are asking in between these two, obsession, compulsion, and the full scenario is with you, go for the compulsion. Don't choose obsession.
Yeah, she is compelled to do this thing.
Yes, compelled. Yes. This is compulsion. For the next one, a 61-year-old man presents with history of constantly thinks about aliens landing in his
backyard. Why not hallucination?
Hallucination, only perceiving, say for example, if it's auditory hallucination, they are going to hear voices. And they are very sure about that. They will not say to you, I know the voices are not there. They will say, no, I am hearing voices. Anyhow, nobody is hearing them. So it's auditory hallucination. They will say, I saw my father, or I saw my mother who has been dead already. Okay. So, and they are very, very sure. It means they will not say, I know my father is dead, but I can't see them. No, they will say, no, I have seen. Or they will say, someone touches me. someone touches me, there is no one in the room, and they will say, no, someone keep on touching me. So it's this one, tactile hallucination. So they have this thoughts here. Most likely it's because of the use of drugs, use of excessive medicine, self-medication. Then we have this one, a 61-year-old man present with history of constantly thinks about aliens landing in his backyard, especially when away from home. Despite knowing that aliens do not exist, see, he knows that there is no such thing like aliens. He feels overwhelmed with the idea that they have landed. He fears that he is going insane. Which of the following is the most likely diagnosis? Here, what do you think? Here is
Obsession.
very good. So, can you please explain why you're not saying it's a compulsion?
Because he's not doing anything to get rid of those thoughts. He's only
Exactly.
obsessed with the idea that there are aliens landing
Yes,
in his.
and he's away from home. When he's away from home, only in that period of time he's having thought in his mind, and he's not going to go back to the home and check in the backyard that there are aliens or not. So action will not be performed, but he has something in his mind that when I away from the home, there must be someone in the backyard like aliens or something. And he realized this thing that this is a stupid idea, or this is something not real. But he's saying to the doctor that I'm having a fear that I'm going mad because of these thoughts. He's not doing anything in order to minimize the thought of fears or anxiety, whatever. But he's asking from his doctor that if these thoughts keeps on coming, I may go insane. So it means that he's just having obsession of this thing. So we'll choose here obsession. Okay. For the next one, we will go for the theory first. Next, we have hypochondriasis, 377. So actually, there are so many types of somatoform disorders where we are going to discuss. Just for now, we are discussing only hypochondriasis. So hypochondriasis means that patients believe that they have some specific disease despite constant reassurance. So most of the time when you have recall or question in front of you, it will say the patient has been undergone the workup of liver cancer, the patient has been undergone the workup of colon cancer or any other cancer. But he keeps on repeating this screening process again and again over years and years and changing the doctor and saying that I know I have this colon cancer. Please go and get it done all the screening tests. Once he has all the normal tests, he will again go to another doctor and he will say, no, get it done all the tests again. I know I have a cancer. Again, the report comes normal. He will again go to another doctor. So multiple times history of, visiting doctors having the same problem, but he has undergone testing. Test result will become normal, but he keeps on changing the doctor in order to, have this thought in his mind that he is having a cancer. So that type of disorder is called hypochondriasis disorder. We cannot do anything with that, only the reassurance, self-assurance, and cognitive behavioral therapy, where we go for the psychotherapy sessions of these patients. We have to realize them that there's nothing like that. But they will not understand this one because it's a mental psychotic disorder. It's involved his body thought. It's not something he has in his mind. He will keep on repeating the same thing despite of having all the real factual tests in front of him, but he is not going to accept them. So this is hypochondriasis. So these questions, how you're going to check for these questions. Say, for example, a 41-year-old man presents to the clinic requesting a complete examination to exclude colon cancer. He recently had some investigations done and provided a list of test of results. He complains that this fear is interfering severely with his work and social activities. Which of the following is the most likely diagnosis? Now see how you're going to differentiate that this is obsession or this is just a hypochondriasis. It's very simple. When something related to person's own body, because somatoform means that body. So when something related to person's own body and he's saying something to you related to his body again and again, most likely a disease condition, then only you will say it's a hypochondriasis. For obsession, he can say anything like aliens in the backyard, like snakes are crawling in the crib, anything, or dirty hand, something related to his own body or outside as well. But for hypochondriasis, always think about the patient will be saying something related to his body, and it should be a disease condition. And most of the time they're saying this cancers and keep on repeating the test and will be normal, and then keep on changing the doctors. So here the answer should be hypochondriasis. So for obsession, it can be with anything, but for hypochondriasis, it's just related to his own body.
Dr. Hira,
Mhm.
why not B and C?
No, factitious disorder is something different. We will look for all the other types of. Let me show you this one. See, obsessive compulsive, you know, right? You can easily rule out that. When it says somatization disorder, for somatization disorder, patient will say to you, "I have pain in my head. I have pain in my abdomen," because there is a clear presentation for all these types of disorder. For somatization, I'm just telling you, the patient will say that I have pain in my head, I have pain in my tummy, I have pain in my leg. So at least four sides he will be saying to you that he is having pain in his hand, pain in his eyes, pain in his here and there, anywhere in the body related to the body. He will say four different sides of pain. Then he will say to you something related to GI problem. Then he will say to you something related. So he keeps on saying you, like you are ended up with the thing that you have something here and there all in your body. So there should be 4 or 5 things which the patient is telling you in order to diagnose a diagnosis of somatization disorder. But here it's not like that. For hypochondriasis, he will just say to you one thing: "Doctor, I have this disease. I know I have this one. Please check this one." So once he has undergone testing, results are normal, he will not satisfied with you. He will change the doctor and he will again do the same thing. And for a particular one disease. But in somatization disorder, he will not say like that. He will say here and there multiple site involvement for the pain, multiple body organs involved. So when multiple things are involved in one person's body, he's saying to you, and you have undergone testing, everything is normal, then you can say it's a somatization disorder. Like he keeps on complaining here and there in the body. Obsessive compulsive, you know very well. For factitious, I will show you this one so that you will have an idea about this one. Individuals fakes an illness to get attention and emotional support in patient growth. Say, for example, I'm saying something for myself just in order to get your attention. So you will pay empathy or you will pay sympathy to me. So that's why I'm saying I'm having this fake illness. Like I'm having cancer just in order to get your sympathy. So that's a factitious disorder. Either psychological or physical illness. Psychological symptoms, maybe he can say to you that I am hearing something, or delusion or depression. It's not true. It's always fakes. Or maybe physical symptoms, he's going to say to you, say for example, sometimes children do like this. They usually say in the morning, "Mommy, I have abdominal pain or tummy ache. I don't want to go to the school." And of course, mommy knows very well that this pain is vague. And he just, in order to have a vacation from the school, or he doesn't want to go to the school, he just said like this. So most of the time we will see like that. Or sometimes in the hospital setting, there's one recall and I think last 2 years back, we have seen multiple recalls in this one. There's one where the patient kept his thermometer inside the tea. So the temperature is like 106, 107, and he's pretending that he's having so high temperature. Anyhow, doctor can easily rule out that someone is having 107 or someone is really having 107 or not. So in order to just to have, having attention of their attendant or other patients, you can say, they're doing like this thing. They cannot, of course, tell a lie to the doctor, but they are doing those things which actually pointing that they have this thing. So that's a factitious one. So inflict life-threatening injuries on themselves. They can harm ourselves also, but there must not be a very much severe in intensity, but they pretend that it's quite severe. Behavior may be compulsive at times, formerly known as Munchausen syndrome. Factitious disorder by proxy, caretaker figure, sign and symptoms in another person. So usually a child, we have just mentioned this example. So just think about this one, that the patient knows that this is wrong, but he keeps on saying that thing just in order to gain attention. That is factitious. But how you're going to differentiate this one with the malingering? Again, it's important. Sometimes the patient is doing all this fake acting in order to get some benefit, not attention. Attention, say for example, I want your sympathy or empathy, that is attention. But if I want some benefit from you, say for example, a criminal act is involved there. Say for example, I want some insurance money, and I just went for this, fake accident in order to show them that I have undergone some serious injury, so that you can pay me my insurance, whatever you have submitted. So something like that, in order to gain some benefit, some real money benefit, or it's a criminal act. That is going to differentiate from the factitious of the malingering. We will see it later. Maybe I can just show this one here. Okay. So see, characterized by this malingering is conscious production of sign and symptoms for an obvious gain, such as I don't want to work and I keep on complaining, or evading criminal prosecution, or achieving financial goal. Say, for example, fake accident, just in order to have the insurance money. So there is not a mental illness. Patients do this by purpose. They have a purpose in their mind that we want that money, or we want that particular financial benefit out of it. So they just keep on repeating the same thing in order to get that thing. So that is malingering. So intentional things in order to have some benefit, that is malingering. Intentional thing just in order to have your attention, or pay, or attendant intention, or any other intention. So that is factitious. So how you're going to diagnose this malingering patient? More frequently in prisoners and military personnel typically diagnosed, and there is a discrepancy between patient complaints and acute physical or lab findings. Say, for example, the patient is showing you that I'm having 107 °F temperature, but when you check his pulse, it's absolutely normal. There is no sweating, nothing in there, no physical sign and symptoms, no lab findings is there, no CRP, ESR is raised. So it means that obviously he's telling a lie, because the lab reports are not matching with his temperature, which he's saying reported on a thermometer, based on just putting the thermometer inside the hot cup of tea. So that is how you're going to differentiate. So let's have a look on the questions. Here the question says, a 30-year-old man with a history of drug abuse presents to the clinic weekly with a variety of health complaints which vary each time and are greatly exaggerated. When he is unaware of being observed, he appears asymptomatic. So see, which of the following is the most likely diagnosis? What do you think? What is this one? He has a history of drug abuse, present to the clinic with a variety of health complaints. So complaints are there which vary each time and are greatly exaggerated. When he is unaware of being observed, he appears asymptomatic. See, here it's a tricky question, because it has two obvious diagnoses, but based on the answer choices, we have to evaluate. So do you think it's a case of depression? No, of course, it's not a clear-cut case of depression. Do you think it's a somatic delusion? There is no term related to somatic delusion. Somatic means body. So the body thing, which has the person is having misinterpretation or misperception about the body. This is not related to that. Somatic delusion itself is not a proper term. If someone is having some thought in his mind that my body is not normal, we usually say it's a body dysmorphic disorder. Say, for example, I'm having the normal facial features, but whenever I see mirror, I used to perceive that my nose is something like that, or my eyes are something like that. So he usually sees a different angle when he look at the mirror. So that's a body dysmorphic disorder. And he keeps on saying, the plastic surgeon, that my nose is not correct and undergone many surgeries based on this thing, that she doesn't like his nose, or she doesn't like his face. So that is something related to somatic body dysmorphic disorder. But there is no such term as somatic delusion. Now, so the two things where you have this malingering and conversion reaction. Conversion reaction we will see later. But what do you think? Based on your knowledge, what you're going to choose here?
Malingering?
Although in order to make a diagnosis of malingering, there should be some financial, or there should be some benefit out of it, right? If the patient is saying something like that, which is not mentioned here, of course it's a recall. Maybe something is missing here. Maybe there is some benefit. Benefit is here, but based on the other answer choices, which she was very conscious that she was very sure that only the choices are there. That's why she has to choose this one, malingering. But if you have something like that, so think about this one, that there must be some financial benefit as well. It's not only about this one that the patient is every time coming and showing the exaggerated symptoms, but when he is unaware of being observed, he appears asymptomatic. So only this term is here where we can say, okay, there is something he wants someone to be aware of. But again, it comes with the thing of this one, when the factitious one, where he wants to gain attention of something. But in factitious one, there should be no illness. But he is having a problem of having drug abuse. So he is the one who usually underwent so many times with the problems as well. And now he's presenting with this one, and he's asymptomatic at all. So it means that he knows how is the reaction of having, a drug abuse and all that. He has undergone illness as well, and now he knows when I do something like this, I will be having this. So that's why he's pretending like that, and he's exaggerated the symptoms because he knows very well what will be the symptoms of this one, because he himself has undergone that type of disease or that type of thing, like he is a known case of drug abuser. So here you can easily say it's a malingering. But for factitious one, the patient doesn't have anything, and it's like there should be no illness. But here in this malingering cases, the patient must be having some illness, or they know they must have in the past, and they are keep on doing this thing in order to get some benefit. So benefit thing is not mentioned here. Maybe it's a broken recall, but you have to go for this malingering based on the answer choices.
Dr. Hira, why not D?
Yeah, convergent disorder. I want you to read this one, conversion. Other than that, you will not get to know this one, because convergent disorders are actually this one. These are personality disorders. Let me pull out this one for you. See, in conversion affects voluntary, motor, or sensory functions indicative of a medical condition, usually caused by psychological factors associated with the labile indifference, unconcerned about impairment. See, the very good example of conversion disorder is this one, that after having domestic violence, the patient comes in emergency department, a woman patient, and she says to you she has paraplegia of all four legs. Like she cannot move her legs, she cannot move her hands. And when you inquire about something, there must be having a great fight at home, or maybe some domestic violence or something there. Means something has happened. The patient has undergone traumatic effect, of course, but the patient is absolutely normal. But she is just pretending owing to the effect of that particular happening at home. So she is going to present in such a way. So you can say it's a conversion disorder. In conversion disorder, the patient is absolutely normal. But she has something in his mind that because of that particular event which has happened, she has undergone this paraplegia, or she cannot see. Although her eyes are perfectly normal, and she will say to you that I cannot see anything. Or so you can say it's a conversion disorder. But upon the result in investigation, when you assure her, she will recognize, okay, it's normal. But it will take some time. So all of this happened because of anything happened, voluntary or involuntary. So some of the time affects voluntary, motor, sensory function. So absolutely everything is normal, but the patient will say, and why it's mentioned here affects voluntary, motor, or sensory? Why the term says voluntary? Like the patient has the control of it. Patient knows I can see, but he keeps on saying to you that he cannot see based on something which has happened actually. So that is conversion disorder. So conversion, we don't do anything. We just reassure the patient, and it will take some time. The patient then realizes, yeah, it's okay, and then he will get to know. Because if it's an involuntary action, the patient, it's not in the patient control. But if it's mentioned voluntary, it means that patient has control over it. But for the time being, the patient is actually pretending like that he cannot see, and it's actually happening. It's actually happening. The patient, although the patient has capability to move, but he has a fear, or she has a fear of that I cannot move, and she doesn't want to move at all. And it always associated with some happening, some event. Most likely it's like when there's a domestic violence, and most likely when there is a big fight or something over that. Mostly patients are presenting like that. So that's a conversion. So in this question, it's nothing like that, right? He's just exaggerating the symptoms, but he has a known illness and he's unaware of being observed. It appears asymptomatic. It's not like that when no one sees her, she is asymptomatic. No, she will remain in that state. If she's having conversion, she will remain in that state for a longer period of time, until unless you reassure her, admitted her in emergency department for some time period, like for 24 hours, and then later you will see the patient will become absolutely normal. Okay. For the next one, we will see theory first. Okay. Then we have this agoraphobia. For this one, we will go for the ambis. It's much more in detail here. So this agoraphobia is an inordinate fear or anxiety of being in situations that are perceived as difficult to escape from, and a situation in which it might be difficult to seek help. Say, for example, the patients are having thoughts that what happened if we are in cinema, all the doors are locked and there is a fire, what will happen? We cannot escape from that area. So because of those thoughts, patient will not go to cinema anymore. Or maybe, if I'm in a public area, I'm in a washroom and washroom door is locked, then what will happen? I cannot come out. So because of this fear, he or she will never go to the washroom whenever they are in the public areas. So it's a fear of anxiety of being in situation. There must be a situation where the patient thinks that, okay, if I'm alone in the lift and the lift blocked, then what will happen? I cannot get rid of it. Maybe I can die. So because of that fact, I can never be visiting in a lift alone. So that is some situation where I have a fear of that particular situation. Maybe that term is actually known as agoraphobia. Symptoms must occur over a period of more than 6 months in more than 2 of the following situations: when using like public transportation, or when open spaces, when in enclosed places, whether lying or in a crowd, when outside at home alone. So you can easily diagnose these are the cases of agoraphobia. So treatment, we can only go for the treatment of anxiety. We can give anxiolytic, we can give antidepressant. We only reassure the patient that nothing will happen. But of course, if the patient has undergone this feeling or despair, you have to reassure your patient. Or maybe if there is too much anxiety based on that, like event has occurred and the patient has anxiety, we can just give anxiolytic or antidepressants. It's mostly only reassurance. So if we go to the question, it says a 38-year-old woman presents with a 3-month history of recurrent intense fear accompanied by irritability, excessive worry, palpitations, and chest tightness. She is avoiding social gathering, fearing of having same symptoms. Like she has a fear that when I go to public or in parties or somewhere, I will start having this irritation. I will start having palpitation. My chest will be having pain, something like that. So because of that fear, she avoids gathering. So physical examination findings are normal. Which of the following medications is the most appropriate first line of treatment? So of course, if she is having fear of this one, so you will always go for SSRIs. SSRIs is the best initial treatment for any type of depression, or start of depression, or maybe anxiety. In order to release anxiety, you will start this, and most likely you will start with fluoxetine. Okay. A 48-year-old woman calls the clinic expressing fear of leaving the house. See, she's having fear of leaving the house and has been inside for 2 months. She becomes anxious at the thought of walking out the front door and is now unable to enter the room containing the front door. So she's having a fear of walking out the front door. So she's scared of the front door, walking out from the front door. So that's why she doesn't want to go outside, and unable to enter the room containing the front door. So any place who's having a front door, she's scared of that front door. So a particular situation. And she's having this feeling for the last 2 months. So which of the following is the most likely diagnosis? Do you think it's a depression, sir?
Agoraphobia.
Agoraphobia. Situational fear. Okay. For this one, we have to go for the theory first. Body dysmorphic disorder. Body dysmorphic, say for example, in the mirror, I can perceive myself something different. And based on that, I request my doctor to go for the plastic surgery again and again. 377. Here, patient believes that some part of the body is abnormal, defective, or mishappen. Say, for example, he is an absolutely normal person, but in the mirror, he's seeing himself like this, or related to his own face. It's especially related to own body, most likely face. So here, we cannot do anything, only just reassurance. So these questions are very clear. Say, for example, here the question says, a 23-year-old man complains of having an unusually prominent jaw. Unusually prominent jaw. He has been seen by 3 plastic surgeons, but each one has refused to do anything because it's apparently normal. He's just having this in his mind. On examination, he appears depressed and has no visible protrusion. The jaw and face are normal. He has past medical history of rhinoplasty and blepharoplasty. Always is done because of his thing. And which of the following is the most likely diagnosis? So what you're going to choose here? He's having normal right now. He has already undergone this plastic surgery, and now he has been to 3 plastic surgeons. All of them refuse to do anything because it's absolutely normal looking. So what you're going to say, it's a dysthymia, it's a hypochondriasis, it's a somatization disorder, it's a body dysmorphic disorder.
Body dysmorphic.
It's clearly a body dysmorphic disorder. Okay, for 10th here, we have to go for the theory first. Okay, next we have dysthemia, 362. Okay. Dysthemia characterized by depressed mood that lasts most of the day and is present almost continuously. Symptoms must be present for more than 2 years. Say, for example, recently the mother died or the father died and the son is having depression of that thing, and he keeps on. Normally, what will happen? Normally, if there is a grief or if there is a bereavement, it only happens less than 6 months. Say, for example, if someone very close to you and he dies, what will happen? We will be in a state of depression, but that state of depression, of course, will not take too much time. It should not take more than 6 months. But if some bereavement, if some grief is there, which is more than 6 months till 2 years, you say it's a dysthemia. Like the depression is so long, and it always relate to some loss of things. Like maybe he has lost his job and he keeps on regretting on that thing for more than 2 years. You say it's dysthemia. Or loss of any particular thing, or loss of parents or something like that, or loss of death of wife. So most likely the answer should be bereavement or grief when it's less than 6 months. Normally a grief time period is less than 6 months. It should not go beyond that. But if it's going beyond up to 2 years or even more than 2 years, we have to say this is dysthemia. So only depressed mood because of loss of something. So symptom must be present for more than 2 years. How you are going to treat your patient? Of course, psychotherapy, normal counseling, reassurance, and antidepressant if it's really needed. So we'll go for antidepressant. So here the question says, a 34-year-old healthy man presents to the clinic with a 2-year history of worsening sad mood, poor appetite, insomnia, fatigue, low self-esteem. So depression symptoms are all here, and feeling of hopelessness. He said that I am hopeless. So which of the following is the most likely diagnosis? What do you think? It's organic mood disorder, depressive disorder, minor depression, or dysthemia. So for depressive disorder, in order to make a diagnosis of depressive disorder, they will not mention anything related in years, because most of the time depression lasts for years and years. It's not a history of 6 months or 2 years. Minor depression, something happening just now, and after a day or two, it's gone. Organic mood disorder keeps on changing. The patient must not be having a sad feeling for the 2 years. It doesn't like that. It doesn't seem to be like that. So it's a case of dysthemia. So whenever the years are mentioned, and especially the 2 years figure is mentioned, because in order to make a diagnosis of dysthemia, there should be some low feeling, sad mood, depression symptoms are there, but it should not be less than 2 years. Should be 2 and more than 2. If it's less than 2, we cannot say it's a dysthemia. You can just say it's just a depressive disorder. Because for depression, we don't have any time limit. But most likely it happens in years and years. Especially this generalized anxiety disorder. It's a habit of, like the moms, they are worried about their children, the stuff and everything. So right from the beginning, they are like that. So when it's so extreme that they even can't sleep because of that, they even can't do anything because of that, then only we get to know, okay, this is a generalized anxiety disorder. It's been for many years. So that's a clear case of this thing. Okay. Then next theory we have panic disorder, 369. Very important. So for panic disorder, it's the experience of intense anxiety along with feelings of dread and doom. So see, there are two things. One is panic attack and one is panic disorder. Panic attack means that I was absolutely normal. I was in the presentation room. I was delivering presentation very nicely, but suddenly what happened? My palpitation started, or I have having this, haven't gone this sweating a lot, or something has happened. I had to leave the room. So everything was going perfectly normal, but something happened instantaneously, or you have to avoid that thing. You should have left that area. So that thing is panic attack. And when it keeps on repeating, you can say the patient is having panic disorder. Similarly, the patient is outside, roaming around, or maybe in the market or somewhere, absolutely normal, nothing happened. But suddenly, what happened? He just he just threw everything and he ran away from that area. So it should be something that is intense anxiety. At sudden, it will start it, and the patient has to leave that area in order to minimize that anxiety. Then that is panic attack. And if the patient is having 2-3 episodes of this one, so it means he is a known case of panic disorder. So attack will be on the same point, and disorder the patient experienced 2-3 times before as well. He knows that this can happen anywhere. It's not a situational one. Not only in the meeting room it happens, not only in the market, not only in the cinema. It can happen anywhere. It's not depending on the situation. So this is accompanied by at least 4 symptoms. So what will happen? The patient will be having too much sweating, diaphoresis will be there, trembling will be there, the muscle twitching will be there, chest pain can be, shortness of breath, fear of dying, chills, palpitation, dizziness, nausea, or some dissociative symptoms like incoordinated movements, paresthesia, numbness of the whole body. So if out of all these things, if any 4 symptoms are there, you can say, okay, this is a panic attack. You have undergone a panic attack and you are a known case of panic disorder. So it should be less than 30 minutes and maybe accompanied by agoraphobia. Of course, there will be a fear and he will get rid of that area. He will get out from that area. He will not be there for long. Once the panic attack started, the patient has to leave that area. So agoraphobia will be there and it should last less than 30 minutes. It's not like that. See, in agoraphobia, the patient will not go to that area again because he has having a fear in mind that when I go to that area, I'm having this one. But in case of panic attack, no, it's not like that. Patient will go to that area again and then it will be absolutely fine. Nothing will happen. But at some instance that something has happened and the patient has to leave that area, then it's a panic attack. So fear of places where escape it felt to be difficult. That's the definition of agoraphobia. Now, typically in women can occur at any time and usually has no specific stressor. Rule out thyroid disease. Of course, we have to check all the metabolic state of the body, hypoglycemia, cardiac disease, but that's only for the supportive, not in order to make a diagnosis of this one. For the treatment point of view, of course, if the patient is in depression, we'll always go for SSRI. The choice is best fluoxetine we have. Or along with SSRI, patient may benefit from benzodiazepine because they are very short acting. Begin with both and then taper the benzodiazepine. So we can start with both of these, SSRI and benzodiazepine, if the patient is frequently undergone this panic attacks. But later on, we have to taper this benzodiazepine. Otherwise, there will be a withdrawal. There will be a dependence on this benzodiazepine. So behavioral and individual therapy can also be very helpful in this case. Let's have a look at the questions. Here it says a 50-year-old woman presents to the clinic with history of anxiety 2 months ago during a meeting at her job. She became very anxious, sweaty, and short of breath. She had to leave the meeting in order to calm down. Although she was doing perfectly fine, she was very good. It's not like that she's having any performance anxiety. There is no performance anxiety. In performance anxiety, the patient is always afraid of giving presentation. The patient, the person will say, I'm absolutely fine in working, but when it comes to presentation, no, I cannot stand in front of public, or I cannot stand in on the stage because and then I will be very nervous. So that's a performance anxiety. Like particularly before the performance, the patient has a fear of it. The patient will not undergo for that presentation at all. But here in this case, everything was normal, but suddenly in the meeting, she has this attack. Since then, she has avoided meeting rooms out of fear that she will have a recurrence of her symptom. Now agoraphobia is there. She doesn't want to be in the meeting room. So which of the following is the most likely diagnosis? What do you think, what can be the diagnosis? Okay, there's a panic disorder or a specific anxiety disorder, or generalized anxiety, or post-traumatic. Post-traumatic, there must be some very traumatic history. It's not like that about presentation or something. It should be some trauma, some loss. Generalized anxiety disorder, it happens anywhere. It's not particularly situational. It can happen anytime, anywhere, in any situation. A specific anxiety disorder will be particularly to any specific condition. And this panic disorder, based on the symptoms. So here the symptoms are mentioned. So for example, sweaty, short of breath, anxiety is there. She became very anxious. She had to leave the meeting in order to calm down. So what do you think?
Panic disorder.
It's a panic disorder. So sometimes this specific anxiety disorder, again, specific anxiety can be with any specific condition. Now, how you're going to differentiate this panic with the specific anxiety? Specific anxiety itself is not a definitive diagnosis. It's a very broad and vague term. In order to make a diagnosis, we have to see what kind of a specific anxiety. Either it's agoraphobia, either the patient is having panic disorder, or the patient is having adjustment disorder, or the patient is having performance disorder. So that should be very specific. It's a very broad term, specific. Other than that, of course, it's clearly differentiated. Okay, for the next one, let's have a look at the theory first. Now, adjustment disorder. Adjustment, as the word indicate, there will be some problem in adjusting. Say, for example, if someone has recently shifted to a new area and he's having problem, like he cannot intermingle with the neighbors, or it's happening with the children, especially when when suddenly you change their schools or areas, they will find it very hard to make new friends. Maybe the reasons are too much nowadays. Bullying is the main reason. Usually children don't want to intermingle with each other, especially when there is a change in the location and something like that. So it will take time to adjust them. Or sometimes it happens that when the child goes to any new area, or maybe any guest house or somewhere, and he stays there for 2-3 days, but he doesn't want to go to potty because he cannot adjust there. Sometimes it's also adjustment disorder where he doesn't want to do anything there. But most likely it's a change of area, change of place. So adjustment disorder, page 379. So characterized by maladaptive reaction to an identifiable stressor, say for example, loss of job, there is divorce, so they will take some time to adjust, because if it's a loss of job, it's a new job, settlement will take time. Or so something they happen to divorce or failure in school, usually occur within 3 months of the stressor and must remit within 6 months of removal of a stressor. So of course it should be in between 3 to 6 months, because if it's keep on continue and the patient has sad feeling and all that, then it comes under the heading of dysthemia. The symptoms: anxiety will be there, depression will be there, disturbance of conduct, severe enough to cause impairment in functioning. So what you're going to do, just reassurance, psychotherapy, both individual and group therapy have been used effectively. Not only individual, you will ask their parents or their family, immediate family members to take care of this thing. So let's have a look at the question. Here it says, an 8-year-old boy recently moved to another city. Soon after moving, school started. But the boy hesitated to make friends with anyone and had a hard time paying attention in class. So which of the following is the most likely? So it's very clear. Here he has some adjustment problem. So you will go for adjustment disorder. Very easy questions as far as adjustment is concerned. Okay. For this one, we have to go for somatization first. Somatization, you remember we have a little bit discussed this one before. Somatization, there must be 4-5 areas of pain. There must be 2-3 things wrong in the system, in the patient's body. He will say something here and there related to his own body. So that's a somatization disorder. See, patient must have at least 4 pain areas, 4 sides, like headache is there, pain in the fingers, or maybe legs, or maybe back. So he will say at least 4 sides of pain. 2 GI problem, like vomiting is there, diarrhea is there, or maybe he will say, I have this gastric problem, I have this heartburning and something like that. Sexual, he will say, I have erectile dysfunction, and 1 pseudo-neuralgial symptoms, maybe he says, I feel dizzy all the time. Sometimes the delusion is there. Sometimes I forgot things. He will say something related to dementia as well. So all over the body, if things are there, at least 4 to 6, 7, 8. If he's telling you at least 8 symptoms all over the body, then you can make a diagnosis of somatization disorder. So overall, here and there in the body, and especially 8 things if you count. So you can say it's a somatization disorder. Somatization means body, pertaining to body. So a 20-year-old woman presents to the clinic with history of, now we will see, she's having abdominal pain. She says she's telling the history that she's having abdominal pain, nausea, vomiting, localized weakness to the right leg, and has history of irregular menses. In the past, she has sought treatment for head, back, joint, and chest pain. She has already undergone so many treatments. Factitious disorder and malingering have been excluded as already. So there is no factitious disorder, that's already ruled out. This is only for your health. Malingering is also already have been ruled out. Now, which of the following is the most likely diagnosis? So based on the choices, what you're going to choose. So she's having so many problems related to her body in the past, also has been undergone for the treatment. So whether it's a case of hypochondriasis, convergent disorder, somatization disorder, somatoform pain disorder, it's not only about pain. She's complaining of vomiting and weakness to the right leg, something related to the neurological as well. She's saying irregular menses, overall body complaints are there. So what do you think? It's a whole body involvement. And the question already says to you that factitious disorder and malingering have been excluded already. So no need to think about this one. So we will go for somatization disorder. Okay. Then for this one, we will go for the theory first. Then we have anorexia nervosa eating disorders, 381. Okay, so for eating disorders, anorexia nervosa, failure to maintain a normal body weight, there is a fear and preoccupation of gaining weight. Although she is not fatty, but she's perceiving herself fatty there. Unrealistic self-evaluation as overweight. So of course, when the diet is too much low, the whole body metabolism will be affected. And amenorrhea is common from low body weight. So the women who are having a low BMI, they usually ended up having this amenorrhea. So deny their emaciated condition, great concern with appearance, and frequently examine and weight themselves. So frequently keep on checking the weight, keep on checking their diet, reducing their diet. They don't want to eat because they have a fear of gaining weight. So that is anorexia nervosa. So lost weight by strict caloric control. It's not like that they are actually doing it for purpose. They want their body to be reduced, having low weight. So strict calorie control they will do excessive exercise, they will use this laxative and diuretic just in order to get out or rid of this purgative situation. They will do fasting, they will not eat anything because they have a fear of gaining weight, and they are perceiving themselves as overweight, and because of that they are doing all this thing, although they are absolutely normal. More frequently teenage girls, they usually do like this, like 14 to 18 years of age. Severe weight loss, of course, very low BMI in these patients. They are hypertensive, of course, everything will be low. Bradycardia, this lanugo hair, very, very thin and shiny hair will be there. Edema, ECG changes can also be there because of the very strict diet. The metabolism, mineral metabolism will be severely affected. We can see potassium deficiency because they are not eating anything, or very less likely eating. There can be arrhythmias because of the potassium deficiency. That's the most common cause of death in these patients. So just think about whenever the patient is there who is having a fear of being overweight, and owing to this fear, they are going to control their diet very strictly. They are doing excessive exercise, they do fasting and all that. So we can say it's a clear-cut case of anorexia. How you are going to treat your patient? Of course, if it's severely malnourished, you will go for, or severely dehydrated, starved, there's an electrolyte imbalance, you have to admit those patients. You have to correct their electrolyte imbalancing. Of course, you are going to correct dehydration. We will always offer psychotherapy sessions, behavioral therapy session. If the patient is in anxiety because of all these things, we will go for the treatment of antidepressant. And what is good about the treatment of antidepressant? Most of the antidepressant like SSRI, they are already having a side effect of weight gain. So ultimately, when you put your patient on SSRI, the patient put on their weight. So to promote weight gain, we can just start this SSRI as well. But SSRI, of course, if the patient is in depression, the starting point is because of that. And then, of course, it's just like, those patients who are having this one PCOS, what we usually do, they're having a problem of infertility, we start glucophage. So glucophage, we are not actually started for their, making this thing because of diabetes or something. We just start in order to Why? Because we want their weight to be reduced, and we know very well that this one, especially this glucophage, is the one, or metformin is the one who is going to decrease their weight, and ultimately it will help them in relieving this PCOS problem or help them in relieving the infertility. So it's something like that. You start one thing for any other reason, but it's definitely going to support the other systems as well. So just like with SSRI, you're starting for in this patient just to reduce the fear of being overweight, but that in other way help your patient to promote their weight gain, because they have a side effect of weight gain, especially SSRIs. So we'll look for this bulimia nervosa also. We will have these questions. Here it will say that characterized by frequent binge eating in a discrete amount of time, lack of control of overeating episodes. Now what happened? They eat a lot. They are very possessive about their weight, but they eat because they have lack of control of this one, of being overeaten. So they do eat, and what happened when they have a fear that, oh, I have already eaten a lot, what they will do? They will just go to the washroom, they will poke their finger, especially in the throat, and they vomit everything. So what will happen? You see these patients having, when you clearly examine their mouth, there will be so much indication of acidic content reaction in their teeth. You can easily imagine that their teeth are so acidic, the pH of the mouth is so acidic, because what they usually do, they do vomiting purposely, because they have a fear that I might gain the weight, but they are having a lack of control over eating. They want to eat a lot, 4-5 burgers at one time, and then what happened? When they realize, oh, I have eaten a lot, I'm very conscious about my weight, they vomit. So they have a habit of eating just in order to, because they have a lack of control over eating, and later on they do vomit in order to nullify that reaction of being overeaten. So you can easily examine their mouth and teeth and pH of the mouth. You can say, okay, they are having too much acidic content in the mouth, and because of that acidic content, there is too much reaction within the teeth. Teeth are almost all damaged because of pure low pH, acidic pH. So accompanied by compensatory behavior to prevent weight gain, they will use excessive amount of laxative or diuretic. Fasting they will do next time, excessive exercise, and self-evaluation influenced by body weight and shape. So it's not like that they don't want to eat. They want to eat, and they have a lack of control over eating. They eat a lot, but then they do something in order to nullify that action. That's bulimia nervosa. The diagnosis is more frequent women later in adolescence than anorexia, most normal weight, but history of obesity. So there was a history of obesity, and right now also they have lack of control over overeating, but they maintain that thing by excessive exercise, by use of laxative, by vomiting regularly soon after eating. So treatment does not require hospitalization until severe electrolyte imbalance, of course, and psychotherapy. And if they are depressed because of all this thing, we'll go for SSRI. So just look at the questions. Here it says a 24-year-old inactive woman presents to the clinic with a 5-month history of amenorrhea. See, amenorrhea, because the one who is having low BMI, there is always presentation of amenorrhea because it's a metabolic disorder. On examination, she has a body mass index of 20. See, 24 years, 20 BMI low, stable for the last 5 years. Last 5 years, the same BMI. Pregnancy test negative, which of the following is the most likely diagnosis? She's actually not eating at all. Why? Because she has a fear of gaining weight. So what do you think? It's an eating disorder, illegal drug use, a pituitary neoplasm, chronic depression. It's not something not related to chronic depression. For depression, there must be something which clearly says in the question that the patient is being depressed over that thing. Pituitary neoplasm, it's not like that. There must be some investigations in order to make a diagnosis of pituitary neoplasm. There must be high level of prolactin, which is the cause of infertility or something like that. Or illegal drug use, there must be a history of drug use here. So it's a eating disorder. Eating disorder and anorexia nervosa are the same thing. Then we have this one. A 19-year-old woman presents to the clinic for a routine physical checkup. On examination, she has fine hair all over the body, that is lanicular hair. She feels fat. And subsequently diets, but BMI is 16. See, 19 years, BMI is 16, but she's feeling fat. Obviously, this thing is not matching with BMI. It means that she has only a fear. She thinks that she's overweight and fat, but actually she's not. Which of the following is the most likely diagnosis? In bulimia, she may be having true obesity in the past. She's not feeling like that. So, but she has a lack of control of eating. She do eat a lot, but here she is not eating at all. That's why the BMI is 16.8. So it's body dysmorphic disorder, generalized body dysmorphic. She must be perceiving something different, but it's not the case here. Generalized anxiety disorder will be over-generalized. It has nothing to do with the eating. So it's a clear-cut anorexia nervosa. Okay, for this one, trichotillomania. First, we will just go for the theory. Okay, here I want to show you in the ambas, this one. See, it's an irresistible compulsion to pull out one's hairs. They have a habit of pulling hairs. So say, for example, head hair, they keep on pulling this one, or maybe body hair, so they keep on pulling this one. So lifetime prevalence is approximately 2%. Of course, females are more involved as compared to males. And clinical features, you will see definite hair loss, most commonly involving the scalp, eyebrows and eyelashes. Even they don't spare the eyebrows and eyelashes. They pluck the hair of eyebrows and eyelashes as well. The pattern of hair loss is usually patchy with hair of different lengths because they have a habit of pulling their hairs. So diagnostic criteria: hair loss due to recurrent pulling out of one's hair. Repeated attempts to stop this behavior results in significant distress. Of course, impairment. It's a psychotic disorder, not due to another medical or mental disorder, for example, skin disease, body dysmorphic disorder. It has no relation with that. It can be separate alone as well. Differential diagnosis, of course, there will be loss of hair, alopecia. You have to clinically evaluate whether it's a true alopecia because of the deficiency of hormones, because of the deficiency in diet or something, or it's really this disorder, mental disorder, where the patient is pulling her hair by her own. So treatment, of course, if it's trichotillomania, you will go for cognitive behavior therapy. If the patient is severely depressed, go for SSRI. For the treatment point of view, a combination of pharmacotherapy and psychotherapy. So pharmacotherapy, SSRI is the first line of treatment. Alternatively, you can go for tricyclic antidepressant or SNRIs, but most likely we are using SSRIs. And then above all, fluoxetine is one of the SSRIs, which is the best drug in all of these psychotic patients. So we can also use antipsychotic, but choose always SSRI when its question is there in front of you. So a 52-year-old man presents to the clinic for a routine physical checkup. He has a history of pulling out hair when under stress. On examination, he has diffuse hair, thinning along with the absence of eyelashes. Which of the following is the most likely diagnosis? There's a clear history of pulling out his hair when under stress, and when you do the examination, even eyelashes, hairs are not there. So it's a clear case of trichotillomania. Bulimia nervosa we already did. We just solved this question. A 15-year-old presents to the clinic with history of tetany, swollen glands, and eroded dental enamel. This eroded dental enamel in young female patients, always think about bulimia. They eat a lot and then they do vomit. So electrolyte test result, normal value potassium 2.8. So less potassium is always pointing towards that they have undergone vomiting episodes. Which of the following is the most likely diagnosis? It's a clear diagnosis of bulimia nervosa because potassium is low, showing that the patient keeps on vomiting. Dental enamel, because once the vomiting is there will be acidic content of the gastrum, and that acidic content will do what? They will erode the dental enamel. So it's a clear indication when you do the mouth examination. So it's a clear case of bulimia nervosa. Okay, so I think we are done with all. That's all for today. Thank you so much. We'll continue on Sunday, inshallah. Thank you, everybody. Thank you. Allah Hafiz.
Thank you.